Suicide is a question of context. You have behind the slides there Winter in Quebec, and it's from painter Jean-Paul Lemieux. So it's about the context of suicide in my province and what we can do. But we will see that what we try to do is also linked to presentation by Professor Tadros, a presentation by Dr. Cao yesterday, and Dr. Ming Li also yesterday. So no conflict of interest. Predicting suicide is difficult. In a population of 100,000 inhabitants, 5,000 during a year will have suicidal ideation. 5% of the population. 500 will make a suicide attempt, 0.5% of the population. But 10 out of the 100,000 will die by suicide. So it's difficult to predict. It represents about 1% of deaths each year in my province, for example. This is the adjusted suicide rate by selected countries. You'll have a look of Quebec, a province of 8 million inhabitants. Our suicide rates were about, on average, 12.4, higher in men than in women. It's not the highest in the world. Australia, United States, and Finland and Japan are higher, but it is higher than on average in Canada, especially Ontario has about a third less to half less suicide during a year. This is the adjusted suicide rate by sex in Quebec as a whole between 1981 and 2018. In the middle, you'll see that it seems to be stable. Okay, thank you. It seems to be stable. But it increased in the middle of 1997, in the middle, highest, and then it decreased by about 25%. The decrease occurred especially in men, as you can see from 1996, about a 25% difference between 1996 and now. Now, what happened, and I won't go in details of this for sake of time, but essentially at the on your right and in the gray one, you can see those are those between 15 and 19. It was very high in 1996, but now it's 65% less in those adolescents. It has decreased in also other age group, but there's a group age 50 to 64, which hasn't changed. It seems that there's been a generational effect to this, but overall it has decreased in Quebec. Now, we can understand suicide maybe by using bottom-up approaches and also top-down. Let's talk about bottom-up. And I'm talking about the psychological autopsy method, which we developed into a systematic method to highlight circumstances of suicide cases and work together for prevention. Essentially, it starts with the coroner office investigation file. We look at the medical records, social records, interview with 1 or 2 bereaved relatives, and then we may use the National Confidential Inquiry on Suicide, which comes from the United Kingdom since 1996, which adapted. We write a case summary, and then we propose this to a panel discussion. The panel is a multidisciplinary panel, including representatives of families with suicide experience. We have psychiatrists, nurses, emergency room physicians, psychologists, managers, and also public health people and nonprofit organizations like the Samaritans sitting on the panel. And then from this, they make a recommendation, especially what had could been done in the past year, but sometime previously for the individuals. And then we look at the standardized needs assessment at the individual, programmatic, and sometimes the system level, especially if we aggregate all the cases. What do we find with those type of studies? Psychological autopsies studies identify the median proportion of mental health problems identified in those type of studies is 91% and 25% in the control group. The proportion of comorbidity between mental disorders and substance use disorders was 38% and 6% for the suicide and control group. Personality disorders are represented a quarter of suicide, and the population etiological attributable fraction for mental disorders in suicide was between 47 and 74%. So that's a huge determinant of suicide from a public health perspective, but it is a rare event. The type of mental disorder that we found, for example, in one study in New Brunswick during the course of a year, 70% of mood disorder, 61% of substance use disorder, psychosis only 7%. So psychosis is rare, even though the risk of suicide is greater in psychosis. Personality disorders, 52%. Comorbidity, 75%, and obviously, again, 93% overall of presence of mental disorders in the course of the last year. When we look at the interventions at the individual level that would have been required, I will look around the clock like this. There was a case follow-up, which was a gap in services. Counseling was a big gap in services. Referral to more specialist level of care or for the emergency room or to the was important. So when we summarize, and this is the results of a study that we did in the east end of Montreal very recently, using exactly the same methods, and we found about the same things. But basically, what would be needed is a deployment of mobile crisis resolution teams, short-term, high-intensity, home-based treatment in emergency departments. Secondly, training of professionals in primary and specialized mental health care on substance use disorders, screening and integrated management. You heard about the presentation by Dr. Didier Jutras to that effect. Public awareness campaigns to seek care for depression and substance use disorders. Access for all, regardless of age, to an effective psychosis treatment. Not only the best treatment that we try to offer for first episode onset, but it should carry on for people who are graduating older to have the same quality of care. And then provide universal access to general practitioner, especially for men that haven't been in contact with specialist services. Now, the population approach, again, rapidly the health determinants of our genetics, environmental, microsocial and macrosocial, lifestyle habits, and services. Services as determinants can also be studied using large administrative databases like you did, Dr. Jutras. So let's look at the principle. So we have in Quebec a surveillance system based on the linkage of major health administrative data sets starting in 1996 to 2021 and updated annually. There's about 65 million new entries, claims by physicians, for example, and there's at least 12 to 20 variable in each. It's accessible through the National Institute of Public Health through an agreement with the Quebec Ministry of Health and Social Services and the Régie d'assurance maladie du Québec, the physician billings. 98% of the population is covered. We have a public managed care system. It's geared toward disease-specific approach as well as an integrated approach. And the linked data that it feeds the Canadian Chronic Disease Surveillance System and the Public Health Agency of Canada with Quebec aggregate data. Alberta, for example, is sending the same variable. Ontario is sending the variable, so you have a picture of some disorders. So rapidly, you have an insurance registry, you have a fee-for-service, you have a drug data public system. It covers about 50% of the population, but more so for people with important diseases like schizophrenia, hospital data, and the mortality registry. So healthcare, thanks to these database, you can establish, for example, in the paper, over a period of 7 years, we had 8,000 people, 81% consulted on an outpatient basis, and about 25% consulted psychiatrists in the past year. Almost 50% went to the emergency department, and half of them were officially for mental health there, and 28% were hospitalized in the past year. Among individuals who had been discharged from the emergency department hospital closest to their death, 30% and 75% respectively died in the month following discharge. So really the gap between the emergency room and being discharged is a key. And you remember the recommendation, for example, for mobile crisis team, for example, that came from our bottom-up approach. Suicide prediction and machine learning. Recent researchers have shown that machine learning can assist in detecting, diagnosis, predicting, and treating mental health problems. There's existing tools in machine learning to predict suicide that have low sensitivity and low positive predictive value, but others think that you can do better, and you've shown it. So a recent meta-analysis concluded that machine learning studies have led to a better prediction of suicide-related outcomes than studies using classical statistical approaches. So we're trying to do it now. So I'll describe rapidly what we try to do. I'll move rapidly just to say that for example, our colleague Ron Kessler studied in the US veteran 6,000 cases of suicide, 14,000 cases by Gradus using the Danish healthcare utilization services. Obviously, the researchers in the US cannot have access to the Danish, or they cannot bring it in the US. The same thing that you cannot bring UK database, and I cannot send the Quebec database outside, but we can run the same parallel protocols the way we want. And then another study of 1,200 suicide deaths in US. But in Quebec, we would have about 20 to 24,000 suicides for our study. So our first study is predicting the population risk of suicide health administrative data from the Quebec Integrated Chronic Disease Surveillance System. And the cohort, the case will start by selecting a group for 10 years, and then validate in the group, in the next group of 10 years. So about 8,000 cases, and the control will be a 5% random sample of living individuals in Quebec from January 2002, identified by the Quebec Integrated Chronic Disease Surveillance System. So basically, we have a dictionary of variables, a cohort, and then we analyze at the Institute of Public Health servers, because the data cannot go outside of it. The type of variables that we will have are individual variables, classic, the cause of death, the psychiatric disorders, psychotropic medication, psychiatric treatment, social demographic, healthcare setting. In the environmental, we have the social deprivation index for each the individuals. At the system level, it's the quality of care, but we also have the budgets by regions for mental health and addiction. And look, haha, okay, so that one you won't see, and you're not supposed to see it because it's preliminary data, but basically we found in the variables there, contribution, as Dr. Lee was saying, we use all the variables that we can, then that are available to produce something. And then we have psychiatric disorders, we have suicide attempts, But also we have socio-economic deprivation, and we have also the mental health budget. That is a determinant. So you can advise at a different level what could be done to improve or decrease the suicide rates by modelizing. If you increase the mental health budget, for example, what would happen in your on the suicide rates? And finally, we are doing a prediction of suicide risk of people presenting to Quebec hospital emergency departments, and that's our next piece of work. Thank you very much.